Thank you, Christiane, and good afternoon, everyone. The topic that has been set before me is the issue of expertise in radiation oncology and medicine. Who has it and who defines it? My name is Edward Halperin. I am the Chancellor and Chief Executive Officer of the New York Medical College, a university founded in 1860 with schools of medicine, dentistry, nursing, graduate studies, and health professions. I have no conflicts of interest to declare. This talk is given in memory of and in honor of Dr. G.J. Danjou. Dr. Danjou passed away last year. He was known to many of you as a preeminent Wilms tumor clinical trialist, co-developer of a staging system for neuroblastoma, the Evans-Danjou staging system, a medical editor and author, and a founder and active participant in national and international meetings, including this organization. It is a great honor for me to speak in his honor and his memory. This afternoon, I wish to address why do we care about defining who is an expert in any branch of medicine? How do physicians and medical physicists seek to establish someone as an expert? What are the structural problems inherent to trying to call anyone an expert? And will this discussion ultimately be rendered moot by the progress of technology? Anyone who is a decision maker must have a system for interacting with experts, whether that is a decision maker for the clinical care of children with cancer, for the management of your department, for the management of your hospital or any other organization. There are various ways of interacting with experts. From United States history, I will offer you 3 examples on the spectrum of how decision makers interact with experts. The presidency of Franklin Delano Roosevelt. Roosevelt is referred to by Justice of the U.S. Supreme Court Oliver Wendell Holmes Jr. as a second-class intellect but a first-class temperament. Roosevelt recognizes that while he is a prolific vote-getter, he is often not a content expert. During his first term as President of the United States from 1933 to 1937, he surrounds himself with professors from Columbia University with expertise in social policy and economics. From this, we get the Social Security system. We get the reform of the United States banking industry. We get the general response in the United States to the Depression. Another example, this organization of professors is referred to by the United States press as Roosevelt's Brain Trust. A second example would be the presidency of Jimmy Carter, previously governor of Georgia, but a graduate of the United States Naval Academy at Annapolis, trained as a nuclear propulsion engineer under Admiral Hyman Rickover. Carter receives expert advice, but perceives himself as an engineer who will master almost any subject and try to figure it out. Thus, Carter puts upon himself trying to respond to an energy crisis, puts upon himself crafting Middle East rapprochement, puts upon himself the solution of the Panama Canal Treaty. Some people say, therefore, that Carter puts too much upon himself and does not know how to receive expert advice. A third example on the spectrum is the current President of the United States, Donald Trump, who has labeled himself, quote, a stable genius who needs no expert advice on anything because he believes he knows more on any topic than anyone might advise him. These are 3 examples of decision makers interacting with the concept of expertise. Why in medicine do we care about defining who is an expert? I will offer you 6 reasons why we are concerned with this topic. The first originates from parents. Because I want my child treated by an expert. That's why it matters. A second reason are offered by your interns and your residents and your medical students. Because I want to be trained by an expert. Third and fourth reasons would originate from hospital administrators and health system governors. Because we want to market this hospital or this cancer center as being staffed by experts in their fields. Because I won't make a management decision about what equipment to buy for this hospital without getting advice from our in-house experts. A fifth reason for our concern about the concept of expertise in medicine comes from the political sphere. I have been elected to office. I consider it a matter of local, regional, or national pride that we should be able to provide for the healthcare needs of our population. Why are you sending patients away to get treated? Why don't we have local experts? I insist that we have local expertise because we ought to serve the local population. For those of you that come from countries with a robust malpractice process, there is a sixth reason we are concerned with experts. Because under the judicial system, we require an expert witness to determine if malpractice occurred. Those are then at least 6 reasons why we all concern ourselves with the concept of expertise. How might we assign the title of an expert to any individual physician or medical physicist? We have 2 general systems. One is obtaining a credential. The other is the concept of assigning expertise based on peer regard or peer esteem. Credentials would include the receipt of an academic diploma or a certificate, the completion of a certain number of years of training, the completion of a certain number of years of training with the provision that you must see a certain number of patients of specified types, passing a local or national examination, publishing books or publishing peer-reviewed articles in the scientific literature, having a shelf covered with awards. These are all tangible ways that a society assigns the title of an expert to a physician. The second general way we do this assignment of being an expert is by peer regard or peer esteem. SIOP is based on this concept. How do you decide who stands at this platform for keynote speeches, panel discussions? You have an executive committee for the meeting who picks people they deem as expert to do so. How do you do that? Could you quantify it, or does it mean I know it when I see it? How would you ever codify that in law? Now, the use of a committee to assign expertise is one extreme in the concept of peer regard. The other, the election of a pope. The pope doesn't have to have a specified diploma, counsel a specified number of parishioners, does not have to have a license. The pope is elected by the College of Cardinals. It is entirely a matter of peer regard. If you are born to the right family and are held in enough esteem by the people, or in some countries, the military, you get to be king. And if some of you chuckle at these examples of pope or king, think about how many people you know in healthcare who get assigned as expert because they have succeeded their mentor, or they hold a title, or they married wisely. Some people are experts because they are the endowed professor of thus and so, and they are the endowed professor of thus and so because they must be the expert, whether they really are or not. The examples of peer regard. Now, the crux of the problem for those of you in the audience who are pediatric radiation oncologists is that you could go out and buy the book I co-edit, read it, and pass a written examination and be given a credential. Cancer in children, however, is rare, and the need to irradiate children with cancer is even rarer. Therefore, there are simply too few cases for most radiation oncologists to obtain extensive, real content expert from on-the-ground experience rather than book training in pediatric radiotherapy. There are simply not enough patients to go around in most countries for anyone to develop a vast experience. This problem we have demonstrated mathematically in this paper in the Journal of the American College of Radiology, using the United States as an example, wherein the average pediatric resident in training, if all cases were evenly distributed, which they are not, would have an absolute minimum number of individual cases to assert that they had a credential in pediatric radiation oncology. How might we solve the problem for pediatric radiation oncology conferring of expertise? We could create subspecialty training systems with some certification or authorization to label oneself as an expert in pediatric radiation oncology. Or we could require all children with cancer to be referred to centralized centers for treatment where there will be people who will develop on-the-ground expertise, and for many countries that would necessitate ignoring national borders. And were you to adopt either of these proposed solutions, you would have to come up with a way to pay for all of that, a non-trivial problem. I now want to offer you 4 deep structural problems which are intrinsic to referring to anyone as possessing expertise in pediatric or pediatric radiation oncology. The problems of presentism, the problem of dirty data, the growing problem of protons, and the tyranny of a p-value less than 0.05. First, the problem of presentism. Time marches on, and we each find ourselves at different times in our lives sitting at a certain place and time. Being viewed as an expert is often a function of where particularly you find yourself seated in time. In 1983, I saw this 6-month-old, which I photographed sitting on grandmother's lap in the hospital. She was treated with external beam radiotherapy for retinoblastoma. The picture on your right is her growing up. She's now 36 years of age. At that time and place, I was supposedly an expert because I knew about half beam blocking for a sharp beam edge and how much to angle the lateral beam to allegedly miss the lens, and how to employ an anterior hanging eye block for external beam radiotherapy. And as the data evolved, 2 decades later, we continue to recognize the growing risk with a continued force of morbidity of second malignant neoplasms from the treatment of retinoblastoma. In the previous session, we saw an example, the 30-some-odd-year lady who told you about her experience with craniospinal irradiation when she was 4.5 in the 1980s. By 2019, I was no longer an expert. I have become, in the view of some published authors, just another one of those evil radiation oncologists who maliciously doused infants with carcinogenic rays and produced second malignant neoplasms in retinoblastoma survivors. Maybe I have become just one of those people who do the same thing wrong for 30 years and like to call that collected clinical experience. Much expertise in medicine is therefore relative. Certainly not all. Take an extreme example, say, of the anatomy of the bronchial tree. If you were an expert in it in 1983 and kept up with changes in cross-sectional imaging, then by the standards of the 1980s compared to 2019, you're still an expert. But if you were allegedly an expert in the management of retinoblastoma with radiotherapy by the standards of the 1980s, you are not still an expert. And this drives home the essential problem of presentism. Presentism is condemning people for not having the good sense and the base of knowledge to live in our own time rather than living and working in another time. We, of course, experience presentism in medicine all the time. What were they thinking? They bled patients for humors being phlegmatic? Ha, ha, ha. They gave gastric ulcer patients antibiotics. Bacteria can't live in the stomach. It's too acidic. Ha, ha, ha. Always remember, when you laugh in situations like this, that we may be all ultimately assured that when you look at an old medical record, chuckle at the foolishness of your predecessors and say, what were they thinking? That a generation from now, someone will read your and my chart notes and chuckle to themselves and think, what were they thinking? CT scans? Ha, ha, ha. Chemotherapy and radiation? Ha, ha, ha. How primitive. That is presentism. The second intrinsic problem of expertise is the problem of data. People assume that because there are clinical data, that the data must be true and that knowledge of the data by itself conveys expertise. But of course, all data is dirty. People formulate the questions which then lead to the generation of the data. People compile the data. People have flaws. Data generated by people, therefore, is usually flawed. Many of you may have read the articles in the newspapers in September from the startup company sold to Novartis, Avixix, with its chief executive officer of Avixix and the chief executive officer of Novartis, in which their new compound for the treatment of a metabolic disease was brought to market at $2.1 US per dose, and it is clear from a review that the data was manipulated to make the product look better than it was. And the product is on the market. Experts also sometimes believe that if a question was asked and answered by data, whether or not there was no randomized clinical trial, that it is sometimes true. Case in point, my colleagues, protons. How many of you in the room have told your hospital administrator or your health ministry that you must have a proton or carbon ion unit at your institution because experts agree that it is a superior form of radiotherapy when cancer in children is rare and the economic models show that it will be paid for by treating locally unresectable adult cancer of the esophagus, lung, or T1S adult prostate cancer? I won't ask you to raise your hands. I already know the answer based on the proliferation of these machines throughout the world. There is, therefore, I might conclude, a lot more information in the world than there is knowledge. The third problem of data and expertise is the tyranny of a p-value less than 0.05, as was recently articulated in an issue of Scientific American by the statistician Nicole Lazar. In statistics, we generally are not seeing the whole universe. We're seeing a slice of it. A small slice, usually, which could tell a completely different story than another small slice. The notion of statistical significance is based on an arbitrary threshold applied to the p-value, and it may have very little to do with substantive or scientific significance. It is too easy to slip into a thought pattern that provides that arbitrary threshold with meaning. It gives a false sense of certainty. We certainly know this from multiple publications showing that where something in a clinical trial had a positive p-value, the efficacy disappears when it is tried on a broad-based population. Many of you will, of course, remember the excellent studies done in Canada on brachytherapy for adult glioblastoma multiforme or intraarterial chemotherapy, where the investigators demonstrated that the patients did better with these therapies because they were self or doctor selected for the therapies, and when you tried to apply it to a broad population, the value went away. A fourth problem now for expertise in radiotherapy is that many of us, including me, have largely become radiotherapy travel agents. I work in 2 public hospitals, one north of New York City and one in New York City in Spanish Harlem, taking care of a lot of poor people who receive a recommendation for proton radiotherapy, and I, as a good clinical travel agent, do the consultation and then arrange for a referral, losing on-the-ground expertise because I am no longer supervising the patients receiving their treatment, but being a travel agent to direct them to another institution for therapy. It is important to consider whether our discussion about expertise in oncology will ultimately be rendered moot by the march of technology. Systems where we can talk to computers which sift large amounts of data and then give us answers, like IBM's machine Watson, may give us a combination of artificial intelligence or augmented intelligence in medicine, which will profoundly disrupt our current concepts of expertise. Perhaps the real power in expertise in the coming generation will be what we used to call librarians, who we now call information specialists, who will augment, with the use of powerful computers, the physician interaction with the patient to determine therapies. This afternoon, I have provided you with 3 ways that decision makers interact with expertise. I have gone on for discussing 6 general reasons why we care about defining who is an expert in any branch of medicine. I have tried to describe how doctors seek to establish someone as an expert, either by credentialing or by the concept of peer respect or peer esteem. I have described for you 4 inherent structural problems related to calling anyone an expert: the concept of presentism, the dirtiness of data, the growing problem of the proton travel agent, and the tyranny of p less than 0.05 and statistics as a slice of a clinical problem. And I've invited you to think about whether our ideas of who is an expert might ultimately be rendered moot by the march of technology. I could, by all rights, end here, but I think I would do a disservice if I did not somehow take a personal stand on the issue. So, who is a pediatric radiation oncology expert? What does it require? It is most succinctly summarized by Sir William Osler, who wrote in 1901, "To study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all." It has been my observation that many physicians at meetings like this express concern about lower-income countries and what they might do for lower-income countries. I think there are 2 areas in which lower-income countries have everything to do for higher-income countries. First, to teach us the problem that if we continue to do studies with 8 and 10 molecular subtypes and forms of therapy and diagnostics which are unusable in the places in the world where 90% of childhood cancer deaths occur, we are doing no one any favor. That we should invest more. Thank you. That we should invest more energy in the design of clinical trials which would be largely applicable across a large swath of the world's population. The death rate of childhood cancer in most of Africa and large areas of Asia are appalling, and the problem is not the ability to do molecular subtyping. It is the availability of any reasonable form of therapy that can be generally applied. Second of all, what lower income countries have to offer higher income countries are volumes of patients to develop on the ground direct patient care expertise not obtainable in books. I thank the organizers for inviting me to speak. Thank you for listening.